Okay, hello everyone. Welcome to our panel on economics, healthcare, and the 2020 election. This is an alumni panel brought to you by the Division of Social Sciences at Pacific Lutheran University. I'm Professor Karen Travis, Chair of the Economics Department, and also moderating with me is Professor Michael Artime of Political Science. We'll briefly introduce our guests, and they will speak about their profession shortly and also respond to a question that we posed to them in advance. Following that, Michael and I will ask follow-up questions and also be able to relay any questions coming in throughout the panel that you are welcome to submit via the Q&A function in your Zoom. Audience members, please feel free to submit your questions at any time.
Okay, so the question that we posed for each panelist is, President Trump continues to legally challenge the Affordable Care Act, while the Biden campaign has announced an intent to uphold it and strengthen it. The Supreme Court will take up the case immediately following the election. Based on your expertise, if the law is revoked or substantially weakened, what changes would you expect to observe? You may choose one of these provisions or any other that is notable in your line of work: elimination of pre-existing conditions, protections, the rollback of Medicaid expansions, the ability of young people to stay on their parents' insurance until age 26, even if not college students, whatever perspective you would like to take.
So first, let's have Dr. Larry Deal. He is a family practice physician and both a biology and economics graduate of PLU. Go ahead, Larry.
Okay, thank you. Yeah, I graduated with an econ major, but a biology minor. So I went straight from PLU to med school in Seattle at University of Washington, and then came out here to Minnesota for residency in family practice and ended up staying. So I've been out here 25 years now. And Minnesota's a little, Minnesota traditionally has been a very blue state. Not so much anymore. It's entered the swing state category, which is kind of a new thing, but Minnesota has the, some would say, dubious distinction of being the only state that voted for Mondale back in 80. Being Mondale was from Minnesota. So anyway, given that background, Minnesota has always had a pretty strong social safety net, basically. And so I've been here 22 years, and so with the healthcare reform that did take place, and there wasn't a huge change in Minnesota because we already covered a lot of people that it wouldn't have been covered in other states, basically. And so, it certainly helped. And, from a physician's perspective, I think a lot of us try not to get pulled into the specifics of policy, and we just kind of generally like to see patients and treat them and do our thing. But certainly if those patients have insurance, it's a hell of a lot easier than if they don't. And so I think in general most physicians, me included, were supportive of the healthcare law in general, just given how many were uninsured before that went into place. And so the threats to dismantle it are pretty alarming. Just the chaos that would ensue, and a lot more uninsured patients. And even now there are some uninsured patients. I don't want to get too much into clinical anecdotes, but just yesterday I happened to see, or actually I had a phone visit with a patient, because we're doing more virtual medicine than we used to. We're doing a lot of in-clinic stuff too, but this patient had a phone visit because he had just moved back to Minnesota and had a new onset seizure. And so he went to the ER, but basically declined hospitalization, but told he had to follow up with, a scan and a neurology consult. And so he called me to kind of arrange that. And so I did a kind of a open-ended referral or order for the CT, and I kind of mailed it to him and basically said, shop around for the best, price. And then also gave him a neurology referral to like 4 different choices. So he could kind of, call them, and how much would a consult be with an EEG, electroencephalogram, and so it's not the ideal way to you know, go about things. But, you know, I'm afraid there would be a lot more of that. And, you know, and so anyway, it's such a complicated thing. Like I said, most physicians, I think, don't want to get into too much into the specifics. We just like to see patients. But, you know, I'd be very concerned about any attempts to, you know, reduce coverage. And I guess I'll leave it at that for now. So.
Keep making the rookie mistake of leaving my mute on. So I'd like to take a moment to introduce Amber Rieke, History, Religion, and Women and Gender Studies grad and Director of External Affairs with DC Health Matters Collaborative. Whenever you're ready.
Having me. So I graduated from PLU in 2007, and I started my career working at a health center in San Francisco that saw low-income patients. I've worked in academic research, and then since graduating with my Master of Public Health degree from the George Washington University in DC in 2014, I've worked in local and state advocacy, mostly focused on improving community access to healthcare and also the conditions that contribute to health. For the last 3 years, I've been with the DC Health Matters Collaborative, and that's a partnership of hospitals and health centers in the District of Columbia. And I guess as some background about Washington, DC, since not everyone might be familiar, we are not a state, not a city. We are a jurisdiction that is about 800,000 people, which is more than several states in population. And we operate as a state when it comes to Medicaid. And just like Minnesota, DC had covered a lot of who the expansion of Medicaid was supposed to now cover. So when the ACA went into effect, that actually freed up a lot of dollars for our jurisdiction to spend on other things. Our organization is actually created because of a requirement in the ACA that's not quite as talked about. And it was actually written by Republican lawmakers to try to bring more transparency and accountability to nonprofit hospitals to serve their charitable missions. So making them pay a little bit more attention to community health by doing a needs assessment and spending their money rather than just collecting bills and making huge profits as a nonprofit. So we, in DC, there are several hospitals, and 4 of them and 4 federally qualified health centers decided to come together to do that work. So we work on things beyond the clinic walls, so more upstream or more at the community level, because 80% of your health is created by things outside of medical care, you know, your environment, your family, your job, your community. And so the medical system is starting to go in that direction. Public health is definitely going in that direction. Let's look at how we keep people healthy, not just in their medical care. So that is what our organization does. So that's kind of the perspective I come to this question with, is working for healthcare institutions that are trying to look at keeping the community healthy, trying to keep people out of the hospital. So if it's overturned, you know, that Medicaid has like 12 million people who are now covered that weren't before the expansion. And then another 11 million rely on the subsidies in the federal marketplace, federal subsidies in the marketplace to buy their own coverage. So it's not just the low income folks on Medicaid that could lose coverage, it's also middle income folks who don't necessarily get coverage through an employer. And when you don't have insurance, you skip medical care, you don't get your annual health screenings, you might not get an early diagnosis for a chronic condition, and then you don't go to the hospital or a doctor until it's an emergency. And so that can be both a health disaster and a financial disaster. So without coverage, hospitalizations are usually subsidized by the hospital because they are required by law to treat you and stabilize you. So that's usually turned into either uncompensated care, charity care, or it follows the patient around as medical debt. And what the hospital isn't spending on hospitalizing folks who don't have Medicaid coverage, it can spend on other things. So it can spend it on the work that's trying to get out into the community and do mobile vans and children's screenings and working on issues like housing and these other things. And it also would threaten their viability as institutions if a large population no longer had Medicaid coverage, and they would have to then step in as the institution to cover that. They might not be viable to stay open, especially in certain locations like in low-income areas. So Dr. Deal spoke about the importance of having that ongoing relationship with a provider. You want to have that. Physicians want to have the ongoing relationship, and when the coverage is interrupted, that care is also interrupted. Access to prescriptions are interrupted, and the building of the relationship and trust is also interrupted, which has real impacts on a patient-provider relationship. So rather than getting rid of Medicaid, I think both the institutions and the providers want to see Medicaid expanded. They want to see it cover more things. They want to see it cover at a higher reimbursement rate so that they can make more money, the money that they spend caring for these patients on treating them. And then for the states and the other jurisdictions, that would then have to come in and cover what the federal government had been paying, because the Medicaid expansion is covered by the federal government at like 80–90% for states. So if a state decided that they wanted to continue to care for those people, they wanted to continue to cover them because it's proven to have better health outcomes, to have consistent coverage, then they have to displace a lot of their budget that would have been spent on, again, other things, education, transportation, housing, all of these other supports that actually keep people healthy would then be spent on insuring people. And the last thing I want to say is that it's not just all about having the insurance, even for people who can afford it or have it through an employer. Losing the ACA would mean rules like the fact that contraception is now covered by the insurance plan at no cost sharing to the patient. So that's a big one for folks who need contraception readily available. And if that was suddenly taken away from them and they didn't have a way to pay for that, that can lead to unplanned pregnancies, which is of course much more expensive and potentially dangerous. So in addition to losing things like prescription benefits and treatment for addiction and all of these other really essential services, it could be really catastrophic for poor folks and very specifically people of color, because they're more likely to be in situations where they're not getting coverage through their employer. And because of historic disinvestment and systemic racism, just don't have as much access to the income that would be required to pay for it themselves. So it would have real impacts for institutions and for states, as well as the obvious impact on individuals.
All right, thank you, Amber. Next, let's hear from Bruce Deal. Bruce is an economics and global studies graduate of PLU, and he is currently with the analysis group as a managing principal in Menlo Park, California.
Yeah, thanks, Karen. And Larry and I are brothers, those of you that are curious with the last name. So I'm the older, wiser of the two of us, and we were a few years apart at, you get rebuttal in a minute here. All right. I was an 87 grad. My wife, Lisa, who I think may actually be on as a participant or as an attendee, she was interested in the panel too, is also a PLU grad. She was a nursing grad at PLU, and she's also spent her career in public health in various capacities, and most recently ran a hospice, and she has lots of post-PLU education as well, including a PhD in public health. So after PLU, I went to graduate school at the Kennedy School at Harvard in public policy and studied health policy, among other things, and then worked a couple different places, but I've been at Analysis Group now for almost 25 years. And it's a large economic consulting firm. A lot of what I do is spend my time in disputes. Mostly I didn't cause them, but I end up testifying as an expert witness in lots of different situations, including a lot in healthcare, which is sort of the lens that I bring as an economist and as someone who has kind of seen the front lines of how the ACA has changed, my practice and the kinds of cases that I see, and ultimately how it will change people's lives as well. So kind of two specific threads that are worth touching on tonight in terms of what I see. So one is this concept of pre-existing conditions. So I will say, I think it was Biden said there were 100 million people that had pre-existing conditions. I mean, that's sort of right in the debate the other night. It's a little bit misleading, but I mean, there's 100 million people who probably have some sort of condition that wouldn't put them in the perfect health category. But for those of you that know much about insurance markets, the way it used to work before the ACA was if you're part of a group plan like your employer or some other thing, you typically got covered regardless of the pre-existing conditions, although sometimes there would be a period of time where you had to wait for 6 months before you get covered for cancer or something like that. If you bought it on the individual market, so if you didn't have insurance through a group plan, you'd have to get what's called underwritten, meaning you'd have to say, go to somebody like Larry and get a health workup, and and then you have to fill out your own application that would say, do you have cancer? Are you pregnant? Are you those things? And if you, depending on what the conditions were, you might get fully denied, or you certainly would get a higher price for the insurance. And under the Affordable Care Act, that has gone away. So if you want insurance under the Affordable Care Act, under the so-called exchanges, where this is separate from Medicaid, because Medicaid doesn't have those requirements either. But if you need individual insurance, whether it's subsidized or not, you can't be denied for pre-existing conditions. From an economist's perspective, of course, the problem with that is that can potentially lead to moral hazard, things like that, where you don't even buy it until you get sick. So that was where the individual mandate came in, so it's gotten a little bit messed up without that. But the idea was, let's require everyone to buy it so they don't just game the system and just get it when they need it. But the good news of that was that it allowed people who had these pre-existing conditions to obtain insurance at least, I hesitate in anything in healthcare to say affordable prices, because nothing is really affordable in healthcare these days. I mean, as an anecdote, when I started studying this back at PLU and then at graduate school, people were saying, oh my gosh, it's like 8% of the GDP. How can we possibly sustain that? And now it's, I think, 18%, something like that. So it's amazing how expensive healthcare is. But anyway, under the ACA, there's no possibility of being denied for pre-existing conditions. So where I would see this before was I would do work, and these were heartbreaking cases, but you see people who basically would lie on their application. They would say, I don't have cancer. It turns out they knew they did, and eventually the insurer would find out, and they would do what's called a rescission. So that would mean that they would say, we're going to take that back. We're going to give you back your premiums you paid, but we're going to take your insurance back, and because we can't underwrite you. And I mean, I did not like doing those cases from the personal part of it. I did a lot of work for payers in those cases, and to maintain their risk pool, they needed to be able to underwrite with people providing accurate information. But it was really a difficult situation. And so if the pre-existing conditions comes back, I mean, that's where we're headed. We're going to head to a world where you're going to have individual underwriting for individuals and families, and you're going to have people who are denied or have to pay very, very high prices for insurance. And it was not a fun place to be, I will say that, especially, I mean, for people who have the misfortune, usually through no fault of their own, or even if it is some contribution, it was still these heartbreaking situations of diabetes or cancer or all kinds of other things. So that's one thing that does sort of scare me a little bit about if the ACA goes away. And there's talk about, well, we're not going to have the pre-existing condition thing come back, but I haven't seen any actual plans as to what that would look like if we didn't have the ACA to have that. I mean, there are some states that had pools for high-risk individuals. Those didn't work very well. They tend to be very expensive, very hard to access. So you end up with lots of people who basically just didn't have insurance, even though they wanted to, but they just couldn't afford it or couldn't even obtain it at all. So that's one element that touches me. The other element that touches me is the Medicaid expansion. So one of the things that I do that isn't actually in litigation is I worked with the Washington State Hospital Association on a big Medicaid program there, which is called a supplemental payment program. So the idea there is Medicaid rates are extremely low in Washington for hospitals. I suspect they are for doctors as well, but I mostly deal with the hospitals there. So there is a federal program that allows states to basically hospitals tax themselves. They use that money to get a federal match and are able to essentially increase Medicaid rates. So it's a self-tax on the hospitals that then ultimately translates into higher Medicaid rates. It basically works because of the federal match out there. And I think, Amber, you'd mentioned that the Medicaid expansion, which you hear that term, what that actually means in practice is that Medicaid used to cover mostly children, pregnant women. Medicaid expansion means it basically covers lots of low-income people, men, women, families, whatever there. So that's the expansion. And as a carrot for the states, the federal government basically said, we'll pay almost all of it. So it's now about 90% paid by the federal government. It started out even higher. I think when I first started on the program, it was like 98% federal government. What that means in practice, again, is that the hospitals in Washington can tax themselves, get this federal match, including this very high match. So the state puts up $1, the feds match it with $9, and they're able to then increase Medicaid rates. So if that expansion goes away, that's going to be a huge blow, not only because you'll have people without insurance, which Larry's talked about, Amber's talked about, but because some of these supplemental programs that are out there that also rely on the federal match. And in Washington State, this is a huge deal. There's 700,000 people in Washington State. About 1 in 10 people are covered under the expansion. So it's a huge deal for Medicaid. And hospitals would rather have Medicaid than uninsured, but they would really rather have the Medicaid that has the nice high match from the federal government because it allows them to do this supplemental program effectively. So we're going to see all kinds of changes like that if we have that repealed, and particularly Medicaid expansion, which is actually quite a bit bigger by count than the individual insurance market out there. So you've got the exchanges and all of that I talked about for pre-existing conditions. That's big, but Medicaid expansion is even bigger in terms of just the count of people that it impacts. And again, in Washington State, it's 1 in 10. And just one last thought on that. I went back and looked, and I saw the earlier estimates pre-ACA being enacted was that Washington State would have something like 330,000 people on Medicaid expansion, and it's over 700,000 now. So it's huge, and it would be a huge blow to people to not have it, and would be a big blow to programs like the one that we help, which basically is about $500 million a year that flows through this program. Not all of it ends up as net benefit to the hospitals in the form of higher rates, but a big chunk of it does. So it's going to have a lot of implications. That's not a particularly one that gets talked about in the debates and things like that, but it's certainly going to be an impact. So with that, I'll turn it back over to, Karen, are you going to do the last introduction, or?
I think it's Michael.
Michael?
That's me. So I'll introduce Amy Spieker. Amy is a political science and econ grad, and her position right now is Director of Community Health and Analysis at Cheyenne Regional Medical Center. Amy?
Thank you guys so much for having me tonight. It's exciting to be a part of this kind of discussion with so many different experts. And it was really great to hear Amber kind of describe all the work she's doing. I'm doing a lot of similar work. After my time at PLU, where I got, as was mentioned, a political science and economics degree, which are both represented here tonight, and I'm very proud of that. I went on to the University of Washington to get my master's in public health. After that, I landed out here in Wyoming, which is one of the non-Medicaid expansion states. So I will actually take you all back to the time before Medicaid expansion and talk about some of the things that we're still experiencing here in Wyoming. So I worked first as a maternal and child health epidemiologist at the State Department of Health. And there I really did get to work with the current population that's served by Medicaid here in Wyoming, like was mentioned, is primarily pregnant women and children. It's very hard for a single adult male or single adult female to qualify for Medicaid here in Wyoming. One of the things that I get to do in my job is I actually run Wyoming's Navigator program, which is funding that comes from the federal government to help enroll people in the marketplace. And, you know, it's pretty disappointing that every year we actually have to turn people away for making too little money. So if they make under 100% of federal poverty level, we actually can't provide them any type of insurance. So that's really a hard thing to have to tell people that, I'm sorry, there's no option for you. And then they do fall, as Amber mentioned, onto our charity care roles, but they often are people that are going to now avoid coming to the hospital or receiving the preventive care that they need. One of the other big challenges that was mentioned that was kind of that would come back if Medicaid if the ACA was kind of rolled back in other places that we're still experiencing here is freeing up the other dollars for other things. So for a mere, I think it is 19 million over 2 years, 18 million in our state over 2 years, we could be bringing in 135 million of federal dollars in match, which is, you know, that's a lot for a community. I also, as Amber mentioned, that DC has more population than many states. Well, that's one of our state is one of those states. We have just under 600,000 people in the state. And so those dollars are really meaningful, especially right now. Wyoming's very reliant on oil, gas, and coal, which have all kind of taken a downward trajectory. And that's how we have paid for a lot of our state government over the years. So right now, as our government is facing cuts, the things that we're cutting are things that could be partially reimbursed through that 90% match. So for example, we just at our local community mental health center cut 18 positions to provide mental health services in our community here. We cut a innovative program. Actually, I think a lot of places have it across the state, but we were the only one, across the country, but we were the only one here in Wyoming that allows for older adults who would qualify for nursing home care to actually stay in their homes and come to a day center and be cared for there to try and avoid some of the costs of nursing homes. But because we are seeing such severe budget cuts at our state level, we're starting to see those cuts to other programs that could be offset by bringing in additional revenue from Medicaid expansion. So as was mentioned about Washington State, with a large percentage of people being affected, between the number of people that would be eligible for Medicaid expansion and those that are currently on the exchange, it's about 1 in 6 Wyomingites. And so it's a big population that we're talking about. And then lastly, I will just say that Wyoming is a very rural state, which, you know, there's rural parts of many parts of our country, and they are being really impacted by the hospital closures that have kind of plagued the rural areas across the country. And Medicaid is one of the things that props those up. And so if we see a decrease in the Medicaid reimbursement rates, or if we see in some states where they have expanded Medicaid a rollback of that expansion, I think we can continue to see rural hospital closures, which then means for some people traveling hundreds of miles to receive care. So I do think that there are lots of implications of what the ACA can do with and without expansion.
All right, thank you all. Michael, is it fine with you if I bring up one of the questions that we got from the audience?
Oh yeah, definitely.
Someone wrote in that they're concerned that in the individual market, in some segments, the premium has basically doubled in a relatively short time, and those that aren't receiving federal subsidies are struggling to maintain that coverage. Their question is essentially, with so much of healthcare dollars being generated through government and taxation, is it actually a sustainable model to have such a high proportion of premiums come through government. Does anybody have a response to that or thoughts on that?
I'm happy to sort of offer a couple of thoughts, because a lot of what I also do working with the payers and providers is, analyzing prices and amounts paid by various types of payers. So certainly from a government perspective, a huge chunk of the federal budget, for instance, is going to healthcare, whether it's the Medicaid match part of it or whether it's Medicare. And that's getting bigger and bigger, and that's actually Medicare is really the much bigger issue in the federal government than Social Security. Social Security needs to be sort of quote unquote fixed, but it's not actually rocket science to fix Social Security. You can extend the retirement age out a little bit. You can tweak the cost of living. I mean, there's some things that need to be done, but it's fixable. Medicare is much harder because it's basically there's no way to just say we're only going to spend $5 billion on it next year. If only we're $5 billion, but it's because it's whatever they're going to spend, whatever they're going to spend. So they're trying to do some things, with managed care and some other ways of trying to get a cap on things, or at least not a cap even, but it's sort of a control it. It's going to be very difficult, is the short answer on that. I think I joked earlier about everyone's panicking at 8% of GDP, and now we're at 18 or whatever it is. It's pretty hard to see with the aging population and technology improvements and things like that. There's certainly things that need to be done and can be done, and I think Amber and Amy and others are working on some of those things to try and keep people healthier and out of the hospital. But it's a serious problem about what are we going to do to finance healthcare in its current state. The reality is, I see it probably continuing to eat up bigger and bigger portions of the budget for the foreseeable future out there. It's also had this impact that on private insurance, and I think the question also mentioned the private market and the exchanges. So right now, private insurers pay about, at least on the hospital side, which is what I know the best, they pay about 2 or 3 times what Medicare pays. And that's what it sometimes gets referred to as cost shifting, where it's basically this idea that because the Medicare and Medicaid in particular don't pay enough to cover costs, private insurance basically ends up carrying the bulk of it. And you definitely see it. That's real, that private insurance is quite a bit more expensive. And that's part of what's led to this Medicare for all concept is, what if we allowed people to privately buy into Medicare or somehow provided it through the government and made that the single payer system? That's a possibility. I would say that's going to have big implications, certainly for hospitals, because Medicare doesn't cover costs currently, and they'll have to either get more efficient or do something. It'll have some impact on doctors' incomes as well. Sorry, Larry, if that goes through, but probably a little less so on that side of it, because the differential is not as big for professionals and physicians. But there's no question that it is an expensive system. It's having a big impact on the federal government, and I think will continue to, and state governments as well, their share of Medicaid and so forth. And there is no easy fix. I think that's sort of one thing I've learned over 30 years of working in healthcare and health economics is, anyone that thinks it's easy to do is kidding themselves. You've got really vested interests, and many vested interests that actually mean well too. It's not that it's just a few mean people that want to make a bunch of money and are rich owners of things. Lots of healthcare is not for profit. Now, whether it's truly not for profit is obviously a question, and I think Amber, you were working on some of those issues before too. But it's a challenge. I don't think it's an impossible challenge, but I think it's going to be a very slow reform, and the demographics are not necessarily our friend here in terms of the aging population and all of that. I mean, I'll end on the thought there that when Larry and I talk, I always ask him if there's been some big outbreak of health so that his job is at jeopardy, and it does not seem to be happening so far, Larry, right, on that. So People need it, and lots of older people need even more healthcare. So that's a few thoughts, maybe not the cheeriest thoughts in the world, but a few thoughts.
Yeah, even apart from the ACA issues, you know, sometimes as physicians, I think ideally we kind of like to be insulated from some of the economics of healthcare and just kind of treat patients and not worry about it. But then you do hear from patients, you know, like when we had this pandemic induced switch to virtual care, you know, as kind of a stopgap measure, my employer Fairview, which is one of the big entities in the Twin Cities, was really pushing virtual care. Okay, let's do all these video visits and phone visits, and they even got some of the insurers on board to increase reimbursement for those kind of visits. But then we started hearing complaints from patients like, you know, my phone visit or my video visit was this much, you know, and a lot of these people, even though insurance covered it, you know, if they have a high deductible plan, which many people do, you know, that's coming out of their pocket, not the insurance, up to a certain amount. And I mean, a lot of the problems are extremely difficult, you know. I mean, another anecdote, one of my patients has this really rare condition, Gardner syndrome, and he's on an experimental drug, and it's $150K a year for this drug, you know, and he's getting it subsidized through kind of the foundation for that Gardner syndrome. And because otherwise, and there's no way he could afford it, you know, and, you know, so with that kind of case multiplied by all these other really nice treatments, and research is great, but it leads to these very expensive, you know, treatments. And I don't have a good answer for how we're going to pay for it all, unfortunately. So
I think it's a tension with private insurance and this private system of healthcare, and what is the government's responsibility, or why would the government pick up this huge tab? But part of the reason the costs are so high is because we have a private system. And so, you know, there was a huge debate in 2010 about whether there would be a public option in the Affordable Care Act. And there was months of debate on whether there would be a public option. And it ultimately didn't pass because it was too controversial to the private capitalistic system that we have set up. And you know, we keep tinkering around the edges, and part of the reason that the insurance companies maybe raise premiums on one hand is because on the other hand, they weren't allowed to price gouge vulnerable people anymore. And so they didn't want to lose their margins. So how do they make that up? The other piece, you know, the time frame of 2016, 17, was a time when the ACA was being, you know, the new administration was telling everyone that their first priority on day one was to overturn the ACA. So there was huge instability in the marketplaces because nobody knew what was going to happen and what that was going to mean for their business. So there was just huge uncertainty where, like, suddenly this is probably too inside baseball, but suddenly the silver plans were more expensive than the gold plans because of all of these rules that they were trying to work within, with huge uncertainty. So when you start to keep taking apart this whole structure that was supposed to stand as one building, and then you keep taking away things here and here and here, everything sort of gets unpredictable and unstable. So that's part of the reason we need political will to tackle these problems. And whether it's Medicare for all or something else, you know, we're making incremental promises. Now it's, you know, the Biden plan is just more of the back to the public option, which was from 10 years ago. So, you know, we'll get there, but we're not quite making the kinds of big changes on either hand, the private side or the government side, to really see certainly not savings in the current system that we have.
I just want to add, maybe not from the insurance market side of things, but, you know, on the GDP side of things, you know, the percentage of that GDP that's actually spent on prevention is less than 3%. And so when we talk about, that's 3% of the 18%, that's not 3%, you know, so it's a very, very small number that we're talking about in terms of prevention. So, you know, one of the graphs that I love, and I was trying to find it and I couldn't just now, but there's a graph that compares in the OECD countries, it compares the social services plus healthcare spending. And, you know, we always talk about how healthcare spending in the United States is so much higher than in the OECD countries. But if you add the social services component of what other countries are doing, they actually spend about equal or more than us, but they're focusing it in different ways. And we can see that reflected in the outcomes that we're having, which I know most of the people on this call know that, you know, we spend the most, but we don't have the best outcomes. And in many cases, we have some of the worst. And so I do think that sometimes we get, maybe it's just our focus. Maybe we need to change where we're focusing our efforts and really maybe be a little bit more long-term in our vision of what we want to achieve, and say that investing in early childhood education, or investing in pregnant women's healthcare, or investing in those things that we know are going to lead to healthier people across the lifespan are worth the investment and worth more than 3% of 18% of our GDP.
Thank you all. I think we've gotten some really good questions in the Q&A. So maybe we'll continue with that. Does that sound good, Karen? Yeah, so Nathaniel asks, as a quick initial question for each of the panelists, how does information asymmetry in healthcare affect your work in the industry? And then as a follow-up, would the end of information asymmetry in the healthcare industry through technological advancement be more or less beneficial for the industry in terms of price and quality? Anyone want to jump in there?
Again, I'm happy to sort of jump in. I think, you know, this is directly relates to the pre-existing condition issue that you know, insurers are either trying to anticipate expected healthcare costs, and to be able to do that accurately, they need to have equivalent information to, you know, patients. And when that information is asymmetric either direction, it becomes problematic, which is one of the issues that comes up in a lot of genetic testing, things like that, where, you know, 23andMe is, you know, should your insurer have access to your DNA, so they can say, oh my gosh, look, you've got the gene for whatever, and that would, I mean, from an actuarial statistical perspective, that would allow everyone to price that accurately, but it obviously raises lots of ethical issues, and it's not obvious we want, well, it's a question of A, do we want more information, and B, who do we want to have that? Do we want to have some information asymmetries? But if you know you're going to need something, then you can go buy it, and you know, there's a moral hazard problem in there potentially too. So it's a very complicated question. I think it's a good question, an insightful question as well. And you know, in general, I think I've found over the years, markets work, I'm an economist, right? So markets work better with transparent information. That's sort of a tenet of efficient markets, is that everyone's got access to full information, but it becomes somewhat problematic when it deals with individuals' health and expected costs and needs and things like that. So it's a thorny subject worthy of probably not just 1-hour webinars, but entire classes that Karen and Michael and their colleagues in philosophy and religion can teach as well, I suspect.
Also difficult because a lot of the medical information that everybody has access to is questionable at best. You know, so many things patients, you know, bring in or talk about, or, you know, a lot of the time it's thinly veiled advertising, you know, pushing whatever treatment or drug or whatever. And so the quality in information is variable. Yeah.
I was going to say the same thing. I wasn't thinking of information for the insurance companies. I was thinking of information for the consumers, for sure. You know, I'm actually running for political office right now. I'm running to represent Wyoming's House District 11. So all you voters out there, no. You know, I was knocking doors, and I was knocking this woman's door, and she was talking about how she had no idea what she was being charged or what services she had received for her husband's cancer treatment. And, you know, she had recently lost a son, and so was also just distraught. And she, you know, felt like she couldn't do anything, you know. And so I don't know that more information necessarily would have helped her, right? So I think about the asymmetry there of she doesn't even know what she's getting or paying for, but she's still showing up and getting the bills, and how does that affect you know, the care she's receiving, her ability to advocate for herself and get the things she needs from the system, regardless of what the insurance company knows about her.
The first thing that comes
Here's another great question about Medicare for All model. So if the Medicare for All model had higher volume and lower prices, who would you expect to be the most negatively impacted with the lower healthcare revenues? Would it be hospital systems, pharma companies, or do we think consumers would actually have less access to healthcare as a consequence?
The first thing that comes to mind for me is that some people have access to a lot of healthcare, and they spend a lot on their healthcare, and they might, you know, there's a lot of literature about the overuse of a lot of technology and diagnostics and testing that really drives up the cost of healthcare. And sometimes, you know, the most seedy of stories are places that will look for a diagnosis that they have these specific diagnostic tests for. So there's a lot of healthcare that is, you know, a lot of people have too much healthcare, and then a lot of people have not nearly enough healthcare. So I do think that that's something, I guess that's an economic question. That's a philosophical question. It's a question of kind of weighing people's rights. It's a very good question. And I think when we talk about a Medicare for All model, it also seems like there are several Medicare for All models, and no one quite really is talking about Medicare when they talk about Medicare for All. You know, this idea, I think the predominant idea of Medicare for All is anyone can get anything they want with no cost sharing. And that's actually not how the real Medicare works. So, you know, I don't think there is necessarily one agreed upon model when we talk about Medicare for All, so it'd be hard to pin that down.
Any other thoughts on that one, or should we? Someone's said here they've been following the debate off and on for around a decade, and they want to know, is there a particular reason why in 2020 we still do not have a national common market for insurance?
That's a great question. I mean, the historical reason for it is insurance has been regulated at the state level for a long time, not just health insurance, other kinds of insurance as well. But it is strange, I will say, from a you know, an economic or a political perspective. I mean, you can explain it in various ways. In my experience, it definitely can lead to some inefficiencies that are out there, and you get these kind of weird state anomalies. But just so people are aware, like, you can't just say I'm starting a national insurance company and just go start selling it everywhere. You literally have to go and get authorized in the states you're going to offer insurance in. And you know, in some case, actually, California is a pretty good example. California is huge, for one. It's a pretty competitive market. Here we got lots of private insurers. Doesn't mean the costs are low or anything, but you do, and you know, so it mostly is fine. Other states, you end up with, say, one payer who's vastly dominant in that state. I don't know what Wyoming's like, for instance, but there are other states where you've got one payer that's just huge. And that's really, a lot of that's an artifact of the state regulation out there. There have been many discussions and attempts, or at least talked about attempts to get rid of that, to say, look, let's have more competition among payers, and let's have, I mean, same thing can be true of licensure of professionals too, right? It's all state licensed. So, you know, what if there was more of a national standard for that? Because there's pretty disparate, you know, acupuncturists are regulated one way, one state, different way another state, things like that. Mostly those don't go very far. I think probably, Michael, you're the best position to describe that, given the politics of that and the vested interests and so forth. But I don't see it, I will say, I don't personally see it changing anytime soon. Other than, I think there's some movement to potentially allow a little more cross-state, payer competition. And I don't know if you saw, there was just recently a settlement that was announced. Blue Cross Blue Shield, which is an association, but every state plan is separate. They got sued for anti-competitive behavior, and they've just agreed to a settlement. And they basically, one of their provisions was essentially not to compete with each other across state lines. I'm slightly overstating it because there is some competition, and for instance, California, you got a Blue Shield and a Blue Cross here, but things like that will reduce some of those barriers. You'll see a little bit more of that, but it's sort of a great idea and concept, I think, to think about, federal government regulating it. I don't see it happening. The vested interests are just so strong out there, but I don't know, others may have different views.
I don't know that I have a view on it necessarily, but I can just say that Wyoming has just one insurer on the marketplace, and it is makes it we have also the highest cost of any marketplace in the country.
There's also some asymmetry in that, like, different areas in the country get reimbursed by Medicare differently, and so it leads to all kinds of weird outcomes. I think like Florida, for some reason they get reimbursed more than like the upper Midwest and so forth. And then even within Minnesota, there's several big entities in the Twin Cities that have formed kind of a pretty good competition over the years. And so the costs are not cheap, but they're cheaper than, a lot of other areas, whereas Southeast Minnesota is dominated by Mayo. And yes, they have good quality, but it's, substantially more expensive. And so it's, there's definitely the competition does help some, I think, for costs. So.
Go for it, Michael.
Yeah, so we have, there's an attendee who asks, how can getting better healthcare for yourself, if you can afford it, be a bad thing? And so they want you to speak.
Yeah, I wonder if this is maybe in response to what I said about high costs. So I didn't say getting better healthcare for yourself. I just said more. And actually in the American healthcare system, more does not equal better all the time. And in fact, there's a lot of waste. And part of the reason why our costs on whole are so high is because of a lot of high flyers, high friendly faces, I think we call them now, super utilizers, who use a lot of resources without getting necessarily better outcomes, and might be hospitalized over and over because they didn't take their insulin regularly because their prescription was cut off because they lost their health insurance or things like that. So there are several, segments of society that might be considered super utilizers, but the comment I was making about just because you can get the fancy test, it might not actually be medically indicated, but it's available to you, so you get it. And that's part of the reason that the costs total are very high in our system. Not the only reason, but one of them.
Just to give an example, I think of that is mammography. So there is mixed evidence out there about whether a 3D mammography is actually better at diagnosing. And Larry probably knows way more about that than I do, maybe. But then we have all of these hospitals buying 3D mammography machines that then they need to pay for. So then they're going to give you a 3D mammography or mammogram. Then that increases the cost, but doesn't necessarily add any value to your diagnostics or your the chance that you're going to catch the breast cancer. And I think that's similarly true of screening recommendations, not just the machine that is going to screen you, but they have made some changes to the recommendations, because it can be negative if you are not at high risk or you are not in the category that should be screened, and you're screened and you have a false positive. Then there's a lot of stress and anxiety, additional tests, invasiveness that come along with that can be really negative and detrimental, not just for your own health, but then also again add to increased healthcare costs because you weren't screened properly.
sometimes you get all these incidental findings on the various screening tests that lead to other evaluation, and occasionally, you know, it does lead to a fortuitous discovery of something that can be treated and cured, but a lot of times you're just kind of in this cycle of ordering more tests, you know, because obviously no providers want to get sued, and so if the radiologist suggests other tests, you're kind of almost obligated to do it, and imaging tests aren't cheap, obviously, and so kind of this endless cycle of whatever. So
Just as kind of a follow-up to kind of return a little bit to the outcome of the election potentially, I think if people want to say any further information about just besides the ACA generally, or what they would say in terms of administrative differences that they would anticipate going forward between a Biden presidency versus a Trump presidency?
Where do we start on that? But I mean, I will say one. Just this is a little bit of an obscure thing, but as the economist perspective on this, it's interesting. So it's not been super publicized, but one of the Trump administration's initiatives has been to provide more transparency out there, to actually have hospitals have to disclose their contracts and their contract prices. I mean, it kind of goes to you know, Larry, your anecdote about the guy who went to shop around for the EEGs and things like that. So hospitals have been very, very, very reluctant, and payers too. They want to keep these prices private, to have that out there, because they basically don't want it publicized what their negotiated prices are for various reasons. And in California, for instance, the average bill is about 4 times what the actual payment is. So if you go in and you say, you know, what's an MRI? It's $5,000, but they're actually getting paid about 25% of that. So that's one thing. If Biden gets elected, I suspect that won't go through. That's something that the Republican, I mean, I will say, full disclosure, I'm probably a moderate Republican these days, is how you'd characterize me. I'm not a Trump guy, but that's one of the things that he's doing that's closer to a traditional Republican view of things, I think, is to say, let's have more competition, more information, better information. That would change things quite a bit, I think, in terms of what information was out there and how people could use it, or at least how others, maybe other entities, would use it there. I think that's something that probably, if Biden gets elected, there's a lot of pressure to not do that, and I suspect that would go away. So I think we'd actually have probably less, maybe not less transparency than today, but I think we wouldn't end up with the more transparency that they're pushing for. So, you know, that's not going to solve all of healthcare's problems, but it's an interesting thing I've been following, because I do a lot of work in payer provider disputes and looking at contracted prices and actual prices. So we'll see how that all plays out.
Something that comes to mind to me that was actually sort of brought up in a different way in the debate was about substance use. And the reason it was brought up was as a personal attack on Biden's son. And at the beginning of President Trump's term, there was a lot of talk about the opioid epidemic and the national emergency of substance use and substance use disorder and overdose deaths. And that has never really been addressed with the force that was promised, and certainly not with the resources that were promised. We haven't really talked about COVID today, but one of the things that is really increasing in the last year is mental health crises and suicidal ideation and definitely drug overdose, which was already on the rise. So I would hope to see a little bit more of a coherent strategy around a national emergency on the opioid epidemic.
well, I guess I'll weigh in. I guess I'd characterize myself as a moderate Democrat, unlike my brother there. But it's actually interesting, among physicians, I saw this one article that a lot more specialty physicians tend to vote Republican, whereas more primary care physicians tend to vote Democrat. And I think, my guess is we on the front line seeing, all comers where, I mean, I work in a pretty poor area of the Twin Cities actually. So I think that definitely kind of, influences my view. And I guess, with these legislators who say, over the course of these years of this debate of, we're not responsible for your health insurance, but I always found it interesting that most of those legislators have health insurance, and so, I think perspective is, a lot of it. And so, how exactly the two, I guess the big concern is, if, the ACA goes away or is substantially altered, there'll just be more uninsured patients and they'll end up in the ER, and we don't want that. So
Well, we're about out of time now. I think we could probably talk about this for several more hours, but I really appreciate everyone's time and want to thank you so much for participating and joining in this great discussion with a lot of different perspectives. So thank you so much.
Thank you all.
Thank you.
thank you.
Nice to see everybody.
Vote.
Yeah, no, that's exactly right.
Yes, vote.
That,
And vote down ballot too.
yeah, 11.
Good luck, Amy.
Thank you.
Yeah,
Yes, good luck in your campaign.
yeah. Good luck to you. Yeah.
Yeah, good luck, Amy. Thanks, everyone.
Thank you.
Thanks.
Bye.